Welcome everyone to this webinar on fertility and intimacy challenges in survivorship care. My name is Katrin Scheinemann. I'm a pediatric oncologist from Switzerland and also the chair of Pancare. And it's a real pleasure to me to be the host for tonight, together with my two co-hosts, which are Cherine Mathot and Tessa Fuchs. They are both project managers within Pancare, also responsible for this project. Cherine is also a survivor herself. They will help with the chat and everything, posting resources, which we are also hoping to get from you. And you have seen the overview and that you know the two faces which are important through the whole webinar, Cherine and Tessa. I have the pleasure now to continue and introduce Pancare to all of you. So next slide, please. One back. So Pancare is the pan-European network for survivorship care. It's important that it is multidisciplinary. So we are not only physicians, but all healthcare professionals, also survivors and parents. And the mission really is to ensure equal access to optimal long-term care and to improve the quality of life for every child and adolescent in Europe after their cancer treatment, which is unfortunately not achieved yet. Next slide, please. How are we trying to do this? We empower survivors. That's quite obvious. We do educational courses. We do annual meetings. We do a lot of plain communication. That's a lot of Tessa's job. We do a lot of research on late effects, and you have seen many of our research projects on our website. We create guidelines because the follow-up really has to be evidence-based. We have a huge network, not only with all the ones within like Pancare, but also with our main partners, which is CIOB and CCI Europe. We spread awareness, also part of the communication group. We develop methods. These are research projects, but also a twinning program to overcome the inequalities, and we increase visibility for the issues. Next slide, please. So let me quickly introduce you to the topic. And this was a survey on childhood cancer survivors in 2022. And you can see here that the issue of fertility was top 3 and that the body images was under the first 7. So this is something which is really important for survivors. And that's also why this topic was chosen. Next slide, please. Regarding fertility, Pancare has done a lot of work in the past, and this is just a small part of that. We created guidelines, as I mentioned before, which are published. So it's like really how to preserve fertility in female and male patients, but as equally important, I would think, is the communication and ethical consideration around this. This is like really a guideline and a very important tool for clinicians all across Europe. Next slide, please. And then regarding intimacy, I want to quickly really share with you something from Switzerland. It's a care example, what we can offer within our own country. That's a whole project, which is called Just Ask Us. And I put it here because it's also available in English. So it's a holistic follow-up care concept focusing on body image, sexuality, and fertility. It's led by a gynecologist and fertility specialist, and it should really have access to suitable information with the whole website. It offers personal support to specified clinics and workshops. It's also opportunities to share information and stories with others. It really should improve the handling of the relevant issues. And the idea is really that's not available so far in all parts of Switzerland, but at least in most of the German-speaking part, to have this expanded service throughout Switzerland. And with this, I'm happy to hand over to Tessa and Cherine for the first interactive part. Thank you.
Thank you very much, Katrin. So welcome also from our side. As Katrin said, Cherine and I are the co-hosts of the webinar today. And as you can see on the bottom panel in your Zoom, there's a Q&A function and a chat function. So if you have any questions during the presentations later, don't hesitate to put your questions or comments or reactions in there, and we will try together with our team member Jeroen to get back to you as quickly as possible or include them in the Q&A part after the presentations. Let's start with the interactive part, I would say.
Yeah, thank you, Tessa. We would like to get to know you a little bit better as a participant. So please take out your mobile phone and go to the URL at slido.com and enter the code. And please answer the following question. We are very curious in which role you attend this webinar. I see a lot of researchers, healthcare professionals, survivors.
Yes. Seems to be quite equal between survivors and healthcare professionals so far.
Yeah.
Let's wait a bit longer, I would say. Wow, we even have some policymakers here. That's also really, really great to see.
That's nice. Yeah.
Yeah.
All right. Thank you very much.
Yes. So with that, we will move on to question number 2. Which is, what kind of fertility or intimacy challenges after CAYA cancer comes to mind to you? Doesn't have to be from personal experience or professional experience. But yeah, just let us know what comes to your mind. Okay, worries and infertility.
Unspoken. Yeah.
Wow, uncertainty,
Some recognizable things. Yeah.
Yeah. I can definitely sense also the emotional side already of this topic in the words that come up.
Yeah, definitely.
Well, we definitely hope that the presentations and the interview today will also cover, at least to some extent, most of these topics. At least I can already recognize many things that we're going to talk about.
Yes, me too. So for our third question, we would like to know if you think about the role of long-term survivorship care in navigating the challenges of fertility, but also intimacy, what comes to mind? What kind of role could long-term survivorship care have? Support. That's a very important one. Information. Guidance.
Caring professionals. I like that one.
Yeah, that's a nice one.
Yeah. Recognition, I think that's always a really important aspect. Exchange with others, that's also so nice. And also in a way what we're doing today. Yeah. I really like all of these associations. So let's hope that today we can make a small contribution to all of these goals. yeah, I would say with that, I will hand it back to Katrin to introduce our first speaker of the night.
Thank you very much, Tessa. So I think our first speaker will tackle the topic of infertility and some of the medical facts and figures. And it's a pleasure to introduce Helene van der Paal, who is the previous chair of Pancare. She works at the Princess Maxima Center in the Netherlands, there in the late effect clinics, and is a medical oncologist by training. So thank you, Helene, for taking the medical part of tonight's webinar.
Thank you, Katrin. I'm very happy to give a little piece of the puzzle, the information. I'm just waiting for my control, right? I should have the controls now. Let me check if I can. Yeah. So I will try to tell you a little bit about fertility, a little bit about the facts and the figures in relation to CAYA cancer survivorship. I did add this slide just to set the scene, as to say, we know that about 80% of CAYA cancer patients become survivors. We also know that the burden of late effects is high. At least 75% has one or more late effect, and that's really very big. With all this late effects, survivorship care is really, really important, is needed. And if we look at the topic of tonight, fertility, around 20% of survivors have fertility problems. There are a lot of, there are guidelines, the International Guideline Harmonization Group guidelines and the Pancare guidelines for surveillance, and they tackle also the topic of fertility. And that it is an important topic is that we have more than 400,000 survivors in Europe. So what else do we know about CAYA cancer survivorship? That, as I said, 1 in 5 survivors may have fertility problems, but more than 80% of survivors have questions about fertility. So it's a really important topic. It's one of the frequently asked questions in my clinic. And the other thing is that fertility problems are different for male and female. And what's the most important is that it's really important to understand the needs and the experienced problems for counseling, for family planning, for counseling about coping, intimacy, referral, all these topics that were mentioned, I think, especially in slide number 3. And this is really important to improve the quality of life of survivors. So if we then go back to the guidelines, there are 6 guidelines, IGHG guidelines, that were translated into Pancare guidelines, and those were translated into plain information. You see on the right-hand side all the websites where you can find the information. And the most prominent one, important for survivorship, are number 1, number 2, and number 6. So although it doesn't seem like that, premature ovarian insufficiency is about female fertility, male gonadal toxicity is about male fertility, and 6 is the obstetric care recommendations, but I will leave those out for today. Number 3, 4, and 5 are about fertility preservation, especially prior to treatment. But number 5, the ethical considerations and the communication is also a very important topic, but I will focus on 1 and 2 today. So who is at risk for female fertility? If you look at that, the right-hand slide will be explained by my colleague Simone Broer later on about why we think female fertility can be at risk. But the most important is alkylating agents, and especially in the higher dose range. I think So if these in my blue circle are the most important treatments. So that's radiotherapy to the ovaries, especially above 10 gray, and that's the alkylating agents. And the alkylating agents, I will explain later what they are, but we don't see under 6 milligram per square meter, we don't see the risk of fertility problems is low. With all the others like cranial radiotherapy, hermetic stem cell transplant, or even if one ovary is taken away, there may be fertility problems, but the most important one is the yellow one. So alkylating agents, that is a type of chemotherapy, and I've written down the 5 most important one, and the cumulative dose will be transformed to the cyclophosphamide equivalent dose. You can find the link here, and we will send the links later on for you to find it. But they will all be recalculated to the cyclophosphamide equivalent dose, and if you had less than 6 grams per meter square, then the risk of fertility is low. So what else do we know about female survivors? And there I look at the research we did in the Netherlands. So I already said that a lot of survivors have a desire for children. Around 12% of female survivors consult a reproductive specialist because of not conceiving. And marital status, and that's not only if you're married, but if you have a partner, plays a role in using assisted reproductive treatment. So if you have a partner, the chance of you going to a gynecologist is higher. And the other thing is that female survivors, when younger than their controls, than their siblings, when they went to a reproductive specialist. Then I have another thing about what can we do for girls and women. Well, we can investigate your fertility. We can talk to you about fertility. We can talk to you about your treatment summary. And if necessary, we can refer you to a gynecologist or fertility specialist. We can help you with the fertility problems. That's basically the same. Refer you and your partner to a reproductive specialist, but also discuss other options with you, help you with finding your way. And the other thing is, of course, really important, if you have problems coping, we can talk to you, we can talk with you, we can refer you to people who can help you, for instance, also a psychologist. And then there's another important question, what about fertility preservation, about after cancer treatment? And I think Simone will tell us more about that. So if we then go to the male fertility problems, again, you have here all the treatments that may cause fertility problems, but the most important one is radiotherapy to the testes, and again, the alkylating agents. And azoospermia, that is if there's no viable sperm in your semen. There is, of course, it's not a yes or no answer in most cases. You have normospermia, so that is normal, and everything in between we call oligospermia. And if there's no sperm, then it's azoospermia. And we see here you have these alkylating agents, and if you had less than 4 grams per square meter, azoospermia is unlikely. So other treatments that may cause problems with fertility are cisplatin, hematopoietic stem cell transplant, and if you have an operation of the testes. So what else do we know about male survivors? About 75% of male survivors have a desire for children. There is a difference whether you have a partner, whether you are employed, and your level of education. So that's different than for female. There it's only whether you have a partner, yes or no. A lower amount of male survivors consult a reproductive specialist compared to the female survivors. So what else can we do? And that is really comparable to what we can do for girls and females. Of course, we can investigate your fertility, and for boys and men after puberty, it's much easier. We can do a semen analysis, and then we can provide some answer. It's not that simple, but at least it's easier than for women. We can refer you, of course, if you have fertility problems. We can discuss other options, and we can help you with coping problems by talking to you, with you, refer you if necessary. And for men, there is maybe less a question, but also fertility preservation after cancer treatment may be a question. So just some practical tips. To know your precise treatment is really important, because that is basically what will inform us about your risk. And the other thing that's also very important is that the general population, 1 in 10 people have fertility problems as well. So it's also common in the normal population. And the other very important positive message is that most survivors will fulfill their desire for children. And please talk to other people, talk with other people about your doubts or questions or whatever you have. And if you have any questions about fertility, please ask your doctor. So there's a lot of people who helped with gaining all this information. I've listed them, and I'm very happy to take any questions.
Thank you very much, Helena. So I'm handing over to Tessa and Cherine to moderate the questions.
Yes, thank you very much. So far, there are no questions in the chat, but I have one myself. Helena, you've been a long-term survivorship care specialist for quite some time, and everything you listed now, referring to psychologists, to fertility specialists, that's, I think, already decent options of possible referrals. But how has that evolved over the years or decades even? How was the situation 10 years ago or even earlier?
Well, as you know, I work in the Netherlands, and we have a national late effects clinic. So we have now all those options. We work together. We have a fertility nurse specialist. We have a very good working relationships with the gynecologists and the fertility specialists, but it is very much work in progress. We have our psychologist. So it's for the Netherlands, I wouldn't say we have an ideal situation, but but it took a lot of time to develop this. And there's much more knowledge about what problems there can be and what we can do.
Thank you, Helene. Another question for you. At what time or what stage do you think fertility should be discussed? Is this already during treatment or only in long-term survivorship care? What is your opinion about
that? You have to start at day 1, because if you want to preserve fertility, your best option is prior to treatment. So that's why we have Irene. So she will talk later during the day, but you have to start talking about risks before treatment. That's not always an option, but then at least you should talk to the patient, later survivor, the parents, the whole way. And the questions are different, I think, before treatment, during treatment, after treatment. When you're 17, you may not be interested. When you're 25, you may, but it's a topic that is very important. It should be on the agenda always.
Thank you.
Yes, and I also see that we now have one question in the chat. Oh, another one is popping in. You are lucky that we are early in time, so hopefully we can cover all of them. But yeah, the question to you, Helene, is that you mentioned that 12% of female survivors try in vitro fertilization. How is the percentage of non-survivors in comparison, if you know?
It's about comparable, and it is not only in vitro fertilization, right? It's referral to a gynecologist for reproductive help with assisted reproductive. So it could be not only in vitro fertilization, but other techniques as well.
Okay, thank you, Helene. Then we have another question in the chat for you. Why do you think, who do you think is best to begin discussing the topic of fertility with survivors? Because, of course, if there are parents or family members involved, how do you bring up this subject?
Well, that's of course. I think I only see adult survivors, right, when they're 18. So I always bring up the topic if people have questions, if they want to discuss it when the parents are there or not. So it's always an open question. And I think it can always should be an option, but to discuss it, as I said before, but of course, age related, of age appropriate.
Yes, thank you. One last question, and I'm also really curious about your answer. How can survivors be proactive in a healthcare system where fertility is not properly taken into account for cancer patients? Do you have any advice or guidance how to be proactive as a survivor?
You have to keep asking and find your champions, right? I think there's more and more awareness, of course, in my clinic, I have a lot of older survivors who were not offered the option of fertility preservation or were too young for fertility preservation. But fertility, I think you should keep asking, and we will help you with this as well in the broader sense of the way within Pancare, within the EU CAYA's net, to make this topic on top of the list.
Thank you. And with that, I will hand it back to Katrin to introduce our next speaker. We will try to get back to you in the chat with the leftover questions that we couldn't cover.
Thank you very much, and thank you, Helene. So one of the topics we had before highlighted was support, and who could give the support would be a fertility specialist. So we are really happy that Simone Broer is here tonight. She's a gynecologist working at the University Medical Center in Utrecht, but a fertility specialist. And she is the person who goes to the Princess Maxima into the survivorship clinic. So Simone, thank you very much for joining us today. And what can a fertility specialist offer?
Thank you for the introduction. And thank you for the invitation to speak to you all tonight. One disclaimer, I have a bit of a cough, so I might shut down my microphone when I need to cough a bit so that it's not too much in your faces through the screen. And then I hope I can get through the presentation okay. So today I was asked to talk to you about fertility options and what would happen after you're referred to a fertility specialist. Next slide. And I would like to first give you a bit of a background about fertility in males and females, and then talk about what happens during a consultation, and then go through some scenarios, mainly about if you are worrying about your future fertility or if you want to conceive at this time. And then I will be happy to take any of your questions. So if we look at the background, can I go to the next slide myself. Yeah. For girls, girls are born with all of their oocytes present. So with age, there is a natural decline of all of the oocytes, of all the eggs with age. And this is why we, as women, we talk about the biological clock. And on average, women will be around 50 when their menstruation ceases, and we call it menopause. And that at that time, there are no eggs left. But also already a few years before, there is an end of fertility, and this is mainly due because of the advanced age and that the quality of the eggs is not good enough anymore to conceive. We go to the next slide. Oh no, sorry, can I go back one slide? Yeah, I just wanted to add that during treatment, if we go back for a second, if you have a treatment, oh, it's not going back, is it? Yeah. Then during treatment, the number of eggs can decline, and that may cause to the decline in the number of eggs and an earlier menopause and an earlier end of fertility. And then with the treatment, it depends on which kind of treatment you have had, and I will come back to that later. So the question then, of course, is afterwards, can I measure the ovarian reserve? So we'll go to the next slide again. And I will try to explain how that works. Yes, next slide. So your follicle pool, your ovarian reserve, is stored in the outer lining of your ovary, so in the little white line on the outside of the ovary. And from that group of what we call dormant egg, your ovary recruits a group of small eggs that it selects to mature. And from that group, you will choose one egg for ovulation. And if you have a lower number of resting eggs, you will only recruit a smaller portion of eggs, which is demonstrated here in the number of 3, just on average, where with a normal ovarian reserve, maybe you have around 10. And if you have a very high ovarian reserve, you will recruit even like 20. And then you can use one for ovulation, and the other eggs will be thrown away by your body. This way, and your body in your ovary it's very smart actually, because it knows that if the number of eggs is lower, it thinks, well, I have to be a little bit more saving with my number of eggs. So if I only give you 3 every month, you choose one and throw away 2, it will last much longer than if I give you 20 every month. We use 1 and we throw away 19. So your body is therefore adjusting it with age or with the decline of your number of eggs. If we look at what I can do with the test, I can only test the amount of eggs that your ovary is giving out to select your ovulation from. So this is an indirect measure about how many eggs your ovary has left. So if you look at the test that we have, if we go to the next slide, we have actually 2 most important tests. The first test is the anti-Mullerian hormone. This hormone is produced by these little eggs in your ovary and reflects the number of eggs that your body gives out. But this number of eggs, it's very between healthy or the normal population. You see quite different values with age, because we already know that women in general have a different egg count and also a different way of recruiting. So it's the spreading with what is normal and what is abnormal is actually quite wide, and there's also a normal physiological decline. And the other test that we can do is with the ultrasound. We actually do the same now. Here on the ultrasound picture, you see an ovary, and all the small dark circles, those are those little eggs that were also drawn in the cartoon. The problem with these tests is the wide variation, and this is caused by that some ovaries are saving earlier than others. So you may have somebody who has a quite low AMH and a quite low antral follicle count, it is called on the ultrasound. But I don't know if this is a person that saves and becomes sparing in recruiting quite early on, and therefore ensuring that it can last for a longer period. Or this is somebody who is really at the end of their ovulations, and we are only looking at the end of the fertility. So the predictive values of these tests are not very good. If we then go to the next slide, I would like to talk shortly about how does it work in boys. This is very different. Boys have testes, and those testes, I would explain, the most simple way to explain, are little fabrics, and they produce sperm. So those can be damaged as well by treatment, but if the fabrics or the testes and the is not harmed too much, they will keep producing sperm, and the numbers between males and females are very different. Because if you look at the previous slide, you see that a woman may have like 200,000 eggs for her complete adult life. In a normal sperm ejaculate, there are 20 million sperm cells per ejaculate. So this is very different when you look at numbers, what is normal and what is not normal. If you want to test male fertility, the best test we have is not hormonal levels, but is the actual sperm count that you can test and see the number of sperm cells and how good they move, and what we call swim, to see how viable the sperm is. So if you then take that into account, and when you come to your consultation with a fertility specialist, if you go to the next slide, then the most important thing is that we first start with what treatment did you have? And Dr. Helena van der Paal already explained that this is very important, because not all treatments are the same and do not have all have the same risk. And then we also have to take into account, did you have fertility preservation before treatment? Did you freeze sperm cells? Did you freeze testes, biopsies? Did you freeze an ovary or eggs? And we also look into other factors influencing your possible fertility, and also to see, is it a question that you are worried for right now, or are you more looking towards the future? And then with that risk assessment, we decide together if we are going to test the fertility by measuring for a woman the ovarian reserve, and for a man by doing a sperm count. Because, like I said, the tests also are not very absolute, so they may also cause some insecurity. So you need to know up front, do I really want to know about the test? Well, if we are going to test, then there is of course a scenario that the test shows that it's very reassuring, and then we can finish the consultation. But what if the tests are non-reassuring? If we go to the next slide, then we can decide either that you say we're going to monitor it closely, because maybe you will have a bit of a lower ovarian reserve, but if I can follow up and see that it's actually quite stable, then there might not be a reason to freeze eggs at that time. For males, it's a bit different, because if you still produce sperm after treatment, we do not necessarily expect that to deteriorate over time, so that you don't really need to monitor it. And because I mentioned the numbers, you don't need that many sperm cells for a possible treatment and pregnancy in the future. For women or men, you can also decide, well, we are worried that in time, when I get to my child wish, and by the time that I want to conceive, I will not have eggs anymore, or I will not have sperm cells anymore, that we decide to freeze also in survivorships. And then for men, it would be sperm freezing. So if we can go to the next slide. And where we store the sperm, it's been frozen at 180 degrees minus Celsius, and then you can keep it for as long as you want, actually. And then depending on the number of sperm cells, we decide how often do you need to freeze to have a realistic amount of sperm cells for a possible future fertility treatment. For women, egg freezing, so in the next slide I give you a bit of an overview. It's a much more invasive treatment. To freeze eggs, you need to stimulate the ovaries to try to mature all the eggs that are present from that little cohort that your ovary has given free, which normally you choose one for ovulation. Now you try to freeze them all. And we first need to mature those eggs with hormonal stimulation. It's about 2 injections per day. And we have to do follow-up ultrasounds, between most do transvaginally, but can also be through the abdomen. But through the vagina, we do an ultrasound-guided pickup of the eggs. The eggs grow in these follicles, and we collect the fluid, and in the laboratory we can find the eggs, and then the eggs we can freeze. The treatment takes about 2 to 3 weeks, and so with the injections and the ultrasounds and the oocyte pickup, it's quite an invasive treatment, and I'm not sure if in all countries this will be reimbursed by healthcare. In the Netherlands, if you have a risk, then healthcare will reimburse this treatment. But it's quite, it's not easy. So what we are as fertility specialists, I don't want to freeze eggs for everyone because it's quite invasive. And so we have to find a balance between people who have a chance that they will actually come back to use the eggs versus trying not to freeze too late when there are no eggs to collect anymore. So this is always a bit of a difficult balance, but we also shouldn't do too many treatments and cause too many discomfort when you might actually not need it. If the scenarios that you are trying to or want to conceive at that time, then we do a full fertility assessment of both partners, and then we make a prognosis of what is the chance of conceiving naturally. And this depends mainly on, have you been trying to conceive yet, or are you going to start to try to conceive? And then we discuss the need of fertility treatment, and with the discussion of the need of fertility treatment, we also take into account, is there already preserved material which we can use? And I think the main focus that I want to emphasize here, it's on the next slide, that also with a low ovarian reserve, so yeah, we see maybe a low AMH level or a low egg count, but you ovulate every month. It does not matter when you choose your ovulation out of a small group of eggs, and your age is then the most important predictor. So as long as you ovulate, there is a chance of a pregnancy, whether or not spontaneously. And the same is true for a low sperm count. As long as there are sperm cells there is a possibility of a pregnancy, and then we have to decide what are the odds for spontaneous pregnancy, or what can we improve those odds a lot with fertility treatment. And fertility treatment, if we go to the next slide, we have so many of them, and it's in 10 minutes I cannot give you a full presentation of fertility treatment, and it was also not the assignment, but there's a lot that we can do, and then we will decide what will suit you and what would actually improve your pregnancy prospects if you compare that to spontaneous chances. So that's what I want to conclude with on my next slide. I think it's really important that if you worry about it, please talk about it so we can inform you properly. An individual assessment is really important because it's not the same for everyone. Fertility preservation might still be an option in survivorship. So if maybe there were reasons not to preserve before treatment, we can assess whether it's something for you to do that in survivorship, but also not freeze for everybody because it's really not necessary. And if necessary, we can use fertility treatment with fresh eggs or fresh sperm cells, or with frozen materials if you have preserved it before treatment. And most survivors will have children, and then I also mean biological children, because all this talk is about preserving the genetic aspect of parenthood, but parenthood is also much wider than only the genetic aspect. So if these options are no longer an option for you, we will also discuss the other options of fulfilling your desire to become a parent. Well, thank you for your attention. That was very quickly what to expect from a fertility specialist, and I'm happy to take any questions.
Thank you very much, Simone. I think we have time for one question, Cherine and Tessa.
Yes, indeed. We are running a bit late, so it's going to be one question only. And I will just take the first one. It's a very specific one, so I'm not sure if you can comment. The question is, if AMH and AFC values are low when testing every year for multiple years, doesn't it mean it's infertility or just ovaries preservation?
If your values are, well, depending on what is low, so if they are too low and there are no eggs left and you do not ovulate anymore, then you cannot become pregnant. But if they are low compared to your peers of your age, but you still have an ovulatory cycle and you are keeping on the same level, it means that your ovary is trying to preserve, being very sparing in using the eggs, but so far it's been doing well in doing so. And as long as you ovulate, it's not said that you are infertile. No, not at all. No.
Thank you very much. Sadly, we have to move on, and Simone has to leave our webinar, so she won't be able to answer the questions in the chat, right?
I will quickly look at the chat and maybe I can answer some in the chat, but then I unfortunately have to go. Yeah.
It would be great, but otherwise me and Cherine will try to answer your questions. Back to Katrin.
Okay.
Thank you, Simone. So we are moving to the next topic of intimacy. And it's great to have Irene here. She's a nurse practitioner at the Princess Maxima in the field of oncofertility. So thank you very much, Irene, for being here. And the floor is yours.
Thank you so much for the invitation to talk to you about concerns on intimacy and sexuality after cancer. I'm seeing if I can have the control. Yeah, thank you. So when we speak about intimacy and sexuality, there are certain points very important. There's me, my self-image, and there's we, our relationship together, and together me and we are a very fine balance. So if there's a problem between me and we, then it's very likely that there will be a dysfunction, and you will find it especially in intimacy and sexuality. So what we find very important in intimacy and sexuality is your physical condition, your mental condition, because if you are feeling fit and if you're feeling happy, then most likely you are fancying for having sex or being intimate together. Intimate doesn't always mean penetration, but being close together, just touching each other is also very important, and it gives in our body, it gives the endorphins, the hormones which makes us happy. So there's more important than just sexuality, and there's more possible in sexuality than just penetration. But if your physical and mental condition or one of those are not fit, then it is very well possible that you have less desire for sex and intimacy. And let's have a look at how sex can feel different after your cancer treatment. Maybe you can have the next slide. So when you have had your oncological treatment, you might feel very tired or fatigued. And if you are tired, of course, you are not in the mood of going to your partner or doing something with yourself. And if you look at the next one, when you experience changes in your body, that might be very subtle, not only the big changes, but also maybe a scar somewhere in your body, or maybe there's a different sensation on your skin. It might influence you very much. And if you still experience stress or anxiety, then you might have feelings which give you a negative effect or desire for sex. And if you are a bit stressful and have a fear of failure, if you can call it like that, then it's less likely that you have an erection or an orgasm which you are happy about, or your partner. And if we look at the next one, we also know that the mucous membranes in your vagina or in the penis, they might have been damaged because of your treatment. And when you experience pain in very sensitive parts of your body, like the vagina or the penis, then your body really remembers that very well. And then your body gives a very quick signal to your mind the next time when you are trying to have sex together, and it will be a negative association. And if we look at the next one, you also can be intimate with your partner without penetration, but if you are used to having sex with penetration, then it asks a very big change of mindset. And maybe it's a change of mindset which is not so easy to make. So here it's also very important to talk about this. And the last one on the slide, especially, how do you feel about yourself? It's very important that you know what you like and what you do not like, and where you are comfortable with. But let's have a closer look in the next slide on specific factors affecting intimacy and sexuality after cancer. We already spoke about your self-image, and your self-image is influenced by so many factors. And the body perception, we just spoke a little bit on it. If you feel insecure because of your body perception, and it might be very subtle, then it also can be a big factor of influence. And all these factors can influence your self-confidence. So if your self-confidence is low, it might be very challenging, or maybe even too difficult for you to talk about doubts or aspects that are difficult for you. So it helps really if your self-confidence is high and if you can vocalize yourself. We also know that the visible and non-visible physical effects of cancer treatment are often influence, and also between your ears. If you're fatigued, if your energy is low, but also, for example, if your body is feeling stiff, if you do not move easily, then it can give you some hesitation to approach your partner, or maybe to do something with yourself. We also know if there are problems, for example, with your skin. Think of effects from radiation therapy, like itching, numbness, or the opposite, hypersensitivity. It can be a big threshold to try something in intimacy or sexuality, because sometimes when your skin is so sensitive, it even when you do something together or yourself, it might be a big trigger for more complaints of hypersensitivity, and of course that doesn't help you in wanting to be intimate. If you experience feelings like shame, insecurity, fear of failure, when we spoke about before, when there are problems in the mucous membranes, also for men in their penis, they might have a big fear of letting the woman down, that they cannot have an erection long enough to make the woman happy. And for men, it can be a big disappointment if they cannot make their partner happy. So all of these aspects can give a big pressure on your relationship. And because of that, we feel it very important that you feel happy about yourself and that you love yourself. And we go to the next slide. And maybe it sounds a bit silly, but if you say every day some sentences on self-love, it can help you to start believing more in yourself and to build up your self-esteem. But it needs to suit you. So you need to be happy with what fits you. So it's up to you where you feel happy with. But we know if you say sentences like, I'm good the way I am, I love myself, I'm grateful for everything I have, I believe in myself, and it can go on, but it needs to fit for you, then you really can build up your self-esteem. And as we spoke before, self-esteem and self-confidence is very important in intimacy and sexuality. Because we go to the next slide. Because if you communicate together with your partner, your intimacy and sexuality only can improve. But therefore, it's very important that you find a way to talk about this together. And we go to the next slide, and to communicate together on intimacy and sexuality. Well, I can tell you from everything I've heard in the consultations, it's one of the most challenging aspects in a relationship. So it sounds very easy, but it is really important to find a quiet place to talk together. You cannot talk together on very personal stuff if you are going from Zoom meeting to Zoom meeting, for example, or if you have to do all kinds of other things. And in a communication, it's very important to express what you yourself, what do you want and what do you like. And that asks a lot of courage. So all these issues are very sensitive, and it's important that you have the courage to express specific words. Even now on screen, maybe the person from the slides can stop now with continuing. Thank you. But even now on screen, I still need to go over a little threshold. But this is very sensitive, and it really asks some courage to talk about this with your partner. And when your partner answers you, and when your partner says some things about this, it is very important that you listen carefully to your partner, because for you it's difficult, but your partner will have the same emotions. So therefore, it's also very important to look careful at what your partner is expressing. So not only listening, but also look at what your partner is non-verbally expressing. And be clear in your language, use specific words. And when your partner says maybe, then probably your partner means no, but ask your partner about this. You need to say to the other one, I hear you saying maybe, but what does maybe means? Can you explain to me? Because that will give it more depth in your communication about this. And you also need to be aware on your own body language. And if you are very sensitive to your partner, you're most likely your partner is very sensitive to you also. So you also can be non-verbal, but you really need to talk about this and don't wait too long. If in your relationship, the relationship continues, and you miss intimacy and sexuality, it can be very difficult when you have developed some patterns in your relationship. When is the point that you do have the courage to talk about this? So that can be very challenging. So with all of these aspects of communication, we do have some tools of what is important, but it's very important to be aware about yourself. And we go to the next slide. And you need to know what does make you feel like not wanting sex. So there are three important aspects. Your feelings are very important, your relationship, and also medical uncertainties. Your feelings we have talked about, for example, tired or sad or uncertain about yourself, that does not help. So you need to recognize your own feelings, and you need to recognize what is going on in your relationship. If there's irritation or lack of confidence, if you are bored with your relationship, then it's very difficult to expect that something is changing. You are part of your relationship. When there are medical uncertainties, some medication can influence the desire for having sex, or when you experience neuropathy, um, then it also can be challenging, or maybe sometimes even too difficult. And not everything is challenging, sometimes something is too difficult. So please talk about this. And we go to the next slide. So we find it very important that you recognize your own feelings, talk with yourself, and talk with your partner, and ask for help. Um, and I think here in the Netherlands, we are very lucky about the organization of care. And not in every country it is so well organized. And not every care is so well paid for in the health insurance system. But please ask your, when you have spoken about this together, go to your physician and ask your physician, this and this is bothering me and bothering us. Where is the place to go to? Can you say something about this? So thank you very much for your attention, and I'm open for questions.
Thank you very much, Irene. We're running a little bit behind, but maybe we have room, Tessa and Cherine, for one question.
Yes, definitely, Katrin. Thank you very much, Irene, for your extensive presentation. We have one question in the chat. So do you address sexuality problems in the late effects clinic, and do you also offer treatment options to survivors?
Yeah, that's a good question. I'm a nurse practitioner on oncofertility, so very often the questions only are about fertility. But yes, I do open the conversation, and I do mention that survivors after cancer can experience difficult feelings on sexuality. And if that is something that applies for that person, then we stimulate them to talk about it. And you asked also if we can refer patients. We do have sex therapists, but those are not paid for. The person has to pay for the sex therapist themselves. But we also have a system in the Netherlands where you can talk with, it's like a kind of supportive nurse from the GP. And they are also very open to talk about questions on sexuality and intimacy. And they are paid for by the healthcare system.
Thank you very much.
Thank you, Irene.
Back to you, Katrin.
Yeah, you will stay on and maybe answer any further questions in the chat. And with this, I'm handing over to Tessa and Cherine for the next interactive part.
So we would like to ask you to take out your mobile phone again, because we have some questions for you. Go to slido.com and please enter the code again. You can see the code. And then we would like to ask you the following questions. When thinking about what you just heard, the presentations you just heard, to what extent do you recognize the fertility challenges? Do you not recognize them at all? Maybe somewhat, maybe very much. Doesn't have to be about your own situation, but to what extent do you recognize them?
Well, it seems very clear that many of you have encountered these topics. Since, yeah, there is no one who said not at all or not really. So yeah, it seems that this is a topic that is very present for many of you.
Definitely. Thank you very much. So we go to the next question.
Yes, I will read out the next question. When thinking about what you just heard, to what extent do you recognize the intimacy challenges? Sorry. I will give you some moments to put in your answers, but so far it's looking very similar. Okay, I see some of you are saying not at all, but the vast majority, I mean 67% say very much. So that's many of you. So I really hope that also with Irene's presentation could also at least provide some guidance, or at least make you feel recognized with the intimacy challenge that you may be facing yourself, or as a professional that you notice that many of your patients or survivors are also facing. Let's move on to our last question. In regards to these topics, what do you think needs to be spoken about more? So also in our first word cloud, I remember the word unspoken. So I'm really curious to hear, what do you think should be talked about more? Doesn't need to be at the long-term survivorship care clinic, but also amongst peers. Yes, I see many things related to sexuality. I think in many cultures that is a very taboo topic, or feels uncomfortable for many of us. So yeah, return to work, impact on your body relation, disabilities.
The stigma, I see, important one.
Ways to communicate with partner. Well, there's a lot to talk about, clearly. And I'm also really excited for the next part of this webinar, where we are going to talk about some of these things. So I think with that, I will hand it back to Katrin to introduce our next part.
Exactly. Thank you very much. So we have talked a lot and learned a lot from healthcare professionals, but I think one view is missing, a very important one, and that's the one from survivors. And I'm very happy that Lone and Iris, who are both cancer survivors, but also partner in life. And as you can see, there's two little ones who make this life quite different, are ready to share with us their experience and their views. So thank you very much. And I think the interview will be done by Cherine.
Yes, thank you, Katrin. Welcome, Lon and Iris. Thank you for participating in this webinar. We are very happy that you can join us and that you will share your stories. Just to inform you all, Iris will answer me in Dutch and I will translate to the best of my abilities. And Lon will just answer in English. So, Lon and Iris, could you maybe please introduce yourself?
Yeah, I was given the task to introduce both. So next to me is Iris, she's 30 years old, and she had non-Hodgkin at the age of 16. And now she's working as a volunteer at the Fintech Maxima Center with Fintech in the Netherlands. And next to that is her mom. And I'm Lon, I'm 29 years old. I was sick when I was almost 6, and I had leukemia. And now I'm producer of the Space Center at the University of Applied Physics, and also applied that. And together we do a lot of stuff. We like board games, shopping, walking in the forest, but interested are basically now.
Just to quickly check with you, I see in the chat that the sound is not really working all too well. Maybe
Okay.
Asta can also help us out. In the meantime, I will just try to translate that Iris is 30 years. At the age of 16, she had the diagnosis of non-Hodgkin lymphoma. She's now a full-time mother and a volunteer in the Princess Maxima Center for the Dutch Childhood Cancer Association, and a proud mom. Lon is 29 years old, had leukemia, is now a producer of educational material at the University of Applied Science in Utrecht, and also a proud dad. They love to do board games together, walk, shop, but since they had children, they have a new hobby, and that is sleeping.
Yeah.
Hopefully now the sound will be a little bit better. And otherwise, maybe I can suggest you to use some earphones. So let me check for now. So could you maybe please shortly tell us how you two met?
Yeah. We actually met at a biking trip from the Silicon Valley line, where we tried with survivors, cancer, to raise money for families who are dealing with child cancer. And we saw each other, and we fell in love. We had a lot of nice conversations. We both equally wanted to win all the challenges of this biking trip. Yeah, and after that we dated a bit, but we didn't like to call it that. We just met as friends. And eventually I told Iris that I like her a little bit more than friends. And luckily she said, "Oh, that's so great, I like you back." And that was when the relationship officially started.
Okay, I will try to translate it again because the sound is still
Oh,
unfortunately
dear.
not really working. Maybe do you have some earphones in? Maybe we can do it like that. In the meantime, I will try to tell what you just told us. You met at a biking trip that was specially organized by the Dutch Childhood Cancer Association. You had a lot of nice and thoughtful conversations together, a lot of fun together. Also about all the challenges you are both facing in terms of your life after cancer treatment. And in the end, you both admitted to each other that you liked each other quite a lot, which turned out to be, or turned out in this nice relationship together.
Yes, we're searching for microphones, but we don't see that there is an option for telephone audio microphone.
In the meanwhile, I will just go on to the next question, Lon, if you allow me, because we already talked about this, of course, together. I've asked you about the impact the CAYA cancer has had on your lives in terms of late effects. And Iris has told me that chronic fatigue has played a large part in her life. And it was a whole process for her to come to terms with this and to accept this and to cope with this. And also memory and concentration issues. And for you, Lon, you said you deal with low energy and also memory issues, which, you also notice in daily life.
Yeah, that's true. We already had one situation that our son had to remind us that we didn't buy any yogurt in the shop that we had still back. And our son is now 2 years old, so he's already becoming our memory.
Yes, so Lon says that their children are becoming their memory for them and remind them what of chores they need to do. So just let me check real quickly. I think the sound is still a bit. It's difficult for participants to understand, right? So I feel really bad about doing this, but I'll just start with the interview and read out the things you told me. So for the next question, I had for you was how you experience your the impact of Kaya cancer in terms of your self and body image, and if this has changed over the years. So Iris, you told me that losing your hairs at the age of 16 was really a sad thing, which made you insecure and had an impact on your self-image. And also that the last 7 years you had a small intestine tube, which you found quite, daunting in the beginning to show to Lon, but also to others in public. But after the first time you were open about this and showed it to Lon and also to others at, for example, the beach, you felt more secure about this, and you could handle people looking at you quite well. Lon, you told me that due to your DEXA treatment, you gained a lot of weight, which also had an impact on your self-image. You also overheard a comment of somebody saying to his mother that you looked quite big, which of course had an impact on how you looked at yourself and your body as well. I hope. Please nod if you think this is correct. Okay, thank you. uh, and of course, I can imagine that you and you supported each other throughout the years in coping with these challenges.
Yeah, 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 we did. Yeah, I don't know what to add to that.
So when we think about intimacy, and in the way that you can both, of course, understand each other's issue, since you're both Kaya cancer survivors. In what ways did you find support with each other? I also asked you that question, and you both told me, and I'm sorry that I have to tell everybody
It's
this,
what it is. Yeah, no, no
but
worries.
you both told me that you were both each other's first lover,
Yeah,
which really helped you in understanding each other as well in terms of insecurities and talking about all the things you were facing, and that you really find comfort in each other, also due to the fact of late effects, but also because you were your first one, and then you
yeah,
can share that experience together. So I think that's really a nice thing that you had together.
yeah. It was nice that none of us had too much knowledge, and that the other one became more of the noob in this field, the beginner.
Exactly.
Yeah,
Yes. So I also asked you about fertility challenges that were on your path, and which you had faced alone or together. So Iris, you told me that the test showed that you had a low ovarian reserve, which could indicate you would go into menopause earlier than the average age. Um, so you and Long had to think about and make a decision very early on in your relationship, only after being together for 1 year, if you wanted to have children, if this was possible. Um, so that was quite, some pressure for you, I can imagine. But you, in the end, decided that the love for each other was so big and the wish for having a child was also very big that you were willing to take on the adventure. The process of becoming pregnant was quite hard. You also had to face a miscarriage, which was, of course, a sad time for you, but eventually, luckily, it worked out pretty well with two children as a result. So we're very happy to hear that, of course.
yeah,
But also, really, it's. I found it very nice of you to hear the struggles you had, because and that you were so willing to be so open about this.
yeah.
Um,
So we were actually at the point that researching uh, other ways of getting pregnant when we found out that we were pregnant. So we almost went to the biggest steps. And then we saw that we were pregnant.
Yeah, so Lon says that they were already thinking about other steps and measures to take, and then finally they found out they were pregnant. So they were very happy about that it eventually worked. So I've also asked you how long-term survivorship care helped you in navigating the challenges along the way. And you told me that actually you were very assertive yourselves. This is some time ago, around 7 years. So you took action and really asked healthcare professionals, okay, I want to know more about my fertility. Can you please do tests? And yeah, unfortunately, after doing the test, you were both actually called by the healthcare professional with the news that they strongly advised you to, if you want to have children, you would have to do this before the age of 30. And actually, both of you really didn't like the way of communicating. So that was actually a good lesson, I think, that is being learned here, that these topics are very sensitive and need to be communicated in such a way that survivors feel safe and heard at the same time. And I can imagine you would feel a bit overwhelmed if you were told this by phone. So that's a good lesson, I think. And also that you were, of course, both very assertive in this process. And I think that, healthcare providers should also have a guiding role to help survivors think about these questions. So that is not only dependent on the survivor itself. Of course, survivors are also encouraged to ask these questions, but I think there's also a role of the healthcare professional in this. So as one of the last question I had for you was how you two together supported each other throughout the years, and how this was actually a different type of support than from, for example, family or friends. But since the audio isn't really that good, I tried to answer it. That the most important thing is that you both know what it's like to be a CAYA cancer survivor, and that you don't need a lot of words probably to explain how you feel, and that you can really feel safe with each other to share anything which is on your mind, and really also can help each other when you have certain tests or in the long-term follow-up care clinic, and that you know what to do to support each other, right? In that sense. So yes, I wanted to ask you, maybe you can write it in the chat as a last question, if you have a message you would like to give to other survivors or healthcare professionals in terms of these two topics about fertility or intimacy challenges, something you like to share from your own experience, please write it in the chat. And I'm very sorry that the audio wasn't working, that we didn't really get the chance to hear you. I hope I have done your answers justice. And I really would like to thank you a lot for participating in this webinar. Thank you, thank you, thank you.
Thank you very much, Cherine, for trying to manage this. And thank you very much, Iris and Lon, to really share your story with us. So we're coming a little bit to a closing, and I would like to ask all speakers, what is the important lesson you have learned today? And as Lon is already typing, I will give him a minute and start with Irene.
Thank you. I think it's so important that we practice the same as we preach to our survivors. We also should ask our survivors, can I talk about this? What are the words I can use? You cannot use every word for everybody. So ask the survivor, I think I want to say something on intimacy and sexuality, but is that also what you want? Please help me use the words.
Thank you very much, Irene. Helene.
I echo those words, and I just think that I would like to add talk or communicate or try to answer your questions, get your questions answered, and I do hope that everybody with fertility problems or questions finds the answers and fulfill their wishes.
Thank you very much, Helene. And Tessa has a written statement from Simone to share.
Yes, so Simone shared with me that a low ovarian reserve, so egg count, does not predict your chances of becoming pregnant at that time. It really does not matter if your ovulation is chosen from a smaller group of eggs. As long as you ovulate, there is a chance of spontaneous conception. But I cannot safely predict how long you will keep your ovulations. Therefore, we need to make an individualized plan. That was her answer.
Thank you very much, Tessa. And Lon and Iris, I'll let you type this in the chat, so that's easier for you. So if I have to summarize, I think certain topics we have seen. So I think it's a plea for all the physicians already in active care to talk about this, to communicate and to keep this communication into the long-term follow-up care, and that also hopefully one day in Europe, in each country, we have services and access to all the possibilities, but also that we learn more, hopefully, how to avoid treatment which makes someone infertile if possible. That's also another thing we have not talked about today, because we really try to adjust our frontline treatment with regards, for example, radiation doses, but also alkylating doses. And with this, I would like to close with a big thank you. Big thank you to a very active audience for all your questions and comments. A big thank you to all the speakers who have, I think, made a really wonderful webinar on a still really challenging topic. And I would like to really thank my co-hosts who are always preparing me with everything. So makes my life really easy to be the moderator of such a webinar. I wish you all a very nice evening, and please stay connected with the next webinar and with EU CAYA's net for all the further developments. Thank you very much.